All right. So good evening. My name is Rich Pizzillo. I'm NEHA's executive director. Let's try that again. And welcome to Webinar Wednesday. This series began in March to help the New England bleeding disorder community stay as informed as possible and to continue to provide resources and connection through a virtual format. We are continuing this educational forum each week at Wednesday at 7 p.m. Tonight's webinar is focused all about genetic counseling. During this interactive session, we will discuss patient cases and better understand how genetic counselors can help those in the bleeding disorder community. We're thrilled that earlier this year, actually this fall, we have another intern with the Boston University Genetics Counseling Program. So Taylor, if you can give me a wave there. Taylor started with us and has been instrumental in helping us really navigate this unprecedented time that we are in. Taylor is a Boston University, as I mentioned, genetic graduate student and a current intern at NEHA. Originally from Nashua, New Hampshire, Taylor spent her undergraduate years studying biology at Stonewall College. After graduating, she worked in patient safety research as a research assistant at Brigham and Women's Hospital in Boston. She is also excited to help patients and families as a genetic counselor. So we're super pumped. This is Taylor's our third intern, and I see Tori on here. Hey, Tori, welcome back to NEHA. Tori's a former intern as well, and I know you're doing great things post graduate school. So before we get started, I just like to go over a couple of webinar points. Your video is totally optional. This is being recorded. It's going to be on NEHA's YouTube channel following the session. It will last for about an hour. We do welcome your participation. So put the things, comments inside of the chat, and we'll ask Taylor at the end. Tech issues, of course, are not uncommon in a virtual format. So don't worry if you need to call back in. So before I turn it over to Taylor, we're going to do some fun polling questions. So if you've never seen this before, you need your cell phone or an iPhone or not an iPhone, a cell phone or a tablet or anything like that. Or you could do it on a web browser as well. But let me share my screen. 1 second. All right, so this is live polling. It's something that's been really fun that we've done. So you're going to text 781-412-7971. And this will create a word cloud. So fill in the missing word. It wouldn't be fall without, and then we'll give it a couple of seconds here and see what comes up. So apple cider, yes. Absolutely. Cider donuts, love it. Apple picking. I see a lot of apples coming on here. Let's see. Leaf peeping, maple syrup, pumpkin everything. Love it, love it. Yeah, all of these things are absolutely spot on. So let's go on to the next question. Fill in the word. The thing I most dislike about the fall is, and let's see what comes up here. Stink bugs happen in the fall? I thought those were in the summer, but all right.
It was scary.
Yeah. Stink bugs, winter's coming, getting colder. Getting dark early. It's crazy that what time is it? 7:05 and it's already dark out. Let's see. COVID and the flu. Yeah, it's going to happen. I hate to say it here. All right, let's go on to the next question. So what is your experience with genetic counseling? So you text 1, that you are a genetic counselor. 2, I've attended genetic counseling and know a lot about it. 3, 4. Wow, I've never seen this integrated circle here. This is kind of cool and new. So I love this. Usually it's a bar graph, but this is very cool to see. So it looks like right now 33% and 33% have said that they've attended genetic counseling, but don't know much about it, and I've never met with a genetic counselor. So that's about 70% have said that. And then of course we have I am a genetic counselor and I've attended genetic counseling and know a lot about the subject. I think I know the 2 people that have said that. So we'll move on to the next question here. How would you rate your understanding of genetic counseling? So this will populate some basic knowledge, new to the topic, some knowledge, strong understanding. So if we look at this, it looks like the basic understanding and new to the topic really does outweigh the rest there. And then we have a tie for the 17%. And then last question, what do you hope to get out of tonight's webinar on genetic counseling for bleeding disorders? This I'll give it a couple of seconds again. We'll populate general understanding, absolutely. We'll see what a couple of others say here. Is there an additional cost? Better understanding about new information? Learn more topics? How can I get one? I would like to know too. Awesome. All right. So with that said, I'm going to have Taylor share your screen and the spotlight's all on you, my friend.
Sure. Thank you, Rich. All right. I'm going to pull up my screen here. Okay. Can you see my screen? Okay, great. All right. So hi, everybody. Again, I'm Taylor Christensen, and I'm a student at Boston University in the genetic counseling program, and I'm the NEHA intern right now. Oops. Okay, so today I'd like to start by giving an overview of what genetic counseling is. Talk about a little bit more specifically what genetic counseling for bleeding disorders looks like. Give an overview of some genetics, and then talk about some case examples, some prenatal case examples and some preconception case examples that I think will help it show what genetic counselors can do for the bleeding disorder community. So let's start with what is genetic counseling. And so genetic counseling is a process to evaluate and understand a family's risk of an inherited medical condition. So that could be a condition like hemophilia or other bleeding disorders, things like cystic fibrosis, and also like hereditary cancer syndromes as well. And a genetic counselor, or a GC, as you may hear me refer to it, is someone who's been trained in medical genetics and counseling. And so we go to a master's program to learn about all certain medical conditions and some counseling skills as well. So what do genetic counselors do? Well, genetics can be complicated, and we know that, and genetic counselors hope to help simplify genetics and make it understandable. And so a genetic counselor usually takes a personal and family history, which helps them get information to provide a risk assessment. They can explain the benefits and limitations of genetic testing, and along with that, ensure that the appropriate test is being ordered. There are many different types of genetic testing, and so it's important to make sure that the correct test is being ordered that's looking for what you're hoping to find. And then once those results come back, explaining those genetic testing results and what they mean for you and for your family's health. And there's a lot of decision making that happens before testing and after testing. And so genetic counselors can help facilitate that decision making process and help you weigh the pros and cons of the decisions. And then, given how complicated genetics is, and it truly is a family affair, and it can be difficult to understand and to process. And so those feelings come with a lot of emotions, and so we can also provide some emotional support. And lastly, we serve as an advocate for patients. So, making sure our patients are getting the services they need, and connecting them with resources, and then, collaborating with organizations like NEHA and letting patients know about things like that. So where do genetic counselors work? You'll mostly see them in a clinic or a hospital, although they do work in research and industry roles and lab roles as well. And those jobs are expanding as the field of genetics evolves. And they're often part of an interdisciplinary team. And so they'll be working alongside doctors and social workers and nutritionists and things like that, and providing that genetics perspective. And there are many different specialties that you'll find genetic counselors in. Traditionally, it was cancer genetics, prenatal genetics, and pediatrics were the main three specialties, but you can see it's expanded to include cardio, metabolic diseases, genomic work, and things like that. And so you'll find them in many different areas. So genetic counseling for bleeding disorders. Genetic counselors often meet with people who have a bleeding disorder or who have a family history of a bleeding disorder and want to learn more about it. Maybe they want to know what their risk is or what the risk will be for their children. And that includes hemophilia, VWD, and other factor deficiencies as well. And it often is in the context of a prenatal, a preconception, or a pediatric consult. So prenatal being during pregnancy, coming to see a genetic counselor, preconception being planning for pregnancy, and pediatric being maybe a child who's having some features and trying to figure out what's going on. So now I'd just like to take a moment to do a review of genetics, since I will mention some of these things as I talk. So starting with cells, our bodies are made up of trillions of cells, and within every cell we have chromosomes, which are microscopic structures that have all of our genetic information in them. And they have our genetic information in the form of DNA, which is this spiral helix here that you may recognize from biology class. And the DNA is made up of these letters, which represent nucleotides. So A, T, C's, and G's are what you see in here. And there's segments of DNA that we call genes. And we have thousands of genes in our bodies. And each gene is responsible for producing a certain protein in the body. And proteins have many different roles in the body, such as, determining like your hair color, carrying out functions in the body that are important, and things like that. And so sometimes there's a problem or a mutation, as we call it, in one of the genes that affects the way the protein is formed. And that is what can cause disease or differences in the way the body can work. And so I mentioned the word mutations, and the mutation is basically a change in that sequence of those letters. And so you could think of chromosomes as like chapters in a book, and genes are more like a sentence in a chapter. And if there's a mutation, that affects the way that the sentence reads. And so here's some examples here. Missense mutation changes one word or letter, and you can see how that changes the sentence. A nonsense mutation cuts the sentence short. And then insertion and deletions either add or get rid of a letter or a word. And so this is a way to think about mutations as I talk about that word related to bleeding disorders. So moving on to the review of the genetics of hemophilia. Hemophilia A and B are X-linked recessive conditions. And so the genes responsible are located on the X chromosome. So we have 23 pairs of chromosomes. You can see them here. And the 23rd pairs are sex chromosomes. So males have an X and a Y, and females have 2 X chromosomes. And so what I mean by X-linked recessive is that for males, since they only have one copy of the X chromosome, if they inherit a mutation in that copy, they will be affected. Versus females have 2 copies of the X chromosome. And so if they inherit a mutation, they're what we call a carrier because they still have one other working copy. So if we look over here to the left, this is the common scenario we see with X-linked recessive conditions like hemophilia. We see mostly males affected, and they typically inherit the mutation from a carrier mother. So in this picture on the left, carrier mother passed on the mutation and her son is affected. And there's a 50% chance that a carrier mother will pass on the mutation to her children, given that, she has 2 chromosomes. And so she could pass on the one with the mutation, or she could pass on the working copy. And then any daughters that inherited it would be carriers. If the father is the one affected, then all of the daughters will be carriers because they get the X chromosome from him and then an X chromosome from their mother. But males, all of the sons will be unaffected because they get this Y chromosome from their father and they get the X chromosome from the mother. So that's how that looks for X-linked recessive disorders. And hemophilia A is caused by a mutation in the factor VIII gene. In the severe form, most people have what we call an inversion, which if you look at this picture to the right, the third line is what happens with an inversion. So you can see that the middle part here was sort of flipped around. So instead of reading A, B, C, D, E, F, it goes A, E, D, C, B, F. And so this middle part was flipped around. So that's what I mean by an inversion. And that's the more common mutation for people who have the severe form. And the mild or moderate form, we see a wider range of different types of mutations. It could have a large deletion or insertion, which means that there's pieces of the gene that are missing or that are added, and some of the other mutations that I talked about. And hemophilia B is typically a point mutation. So that is like a one letter change or a smaller change, not a flipped around part like hemophilia A. And this is caused by mutation in the factor IX gene. Both of these are on the X chromosome, as I mentioned. So why do some female carriers have symptoms? You know, based on what I just talked about, I said it's mostly males affected. Does anybody know why some female carriers can have symptoms? If anybody wants to jump in, I'll give you a second, or I can take it away.
Can I take a guess?
Sure.
It could be genetic, or maybe because their factor levels are lower?
Yeah, so if you do have factor levels that are lower, you could have features, and your factor levels can vary, you know, with things like pregnancy and things like that. But the reason that genetically we say is X chromosome inactivation, which basically means that, as I said, females have two copies of, we had some comments I see up here. As I mentioned, females have two copies of their X chromosomes. And what happens is the cells inactivate one copy. And just by chance, sometimes some people have more cells that are expressing the non-functioning gene, and that's what causes symptoms. So if you look at this picture on the right, this one here shows skewed X chromosome inactivation, where there's much more of this red form of the gene being expressed. And in the case of hemophilia, this would be like more of the gene with the mutation not being expressed. So this person here, we would expect to maybe have some symptoms, versus here it's pretty evenly distributed, and so they still have a lot of that working copy being expressed, and so less likely to have some symptoms there. And then we see about 10% of female carriers have symptoms. And so my next question for you is, you know, we talked about that hemophilia A and B can be inherited, or typically is inherited from a carrier mother and then a son being affected. How come some individuals are the first in the family to have hemophilia? Does anybody know?
Feel free to put it in the chat, or you could just unmute yourself. It looks like mutations.
Yeah, so spontaneous mutations. So sometimes about 30% of cases arise from a spontaneous mutation, which means that they didn't inherit it from their parent. It's just something that arose just by chance. Another possibility is that the parent was what we call mosaic for the mutation. And so this means that most of their cells here, if you look at this picture, have the functioning gene, but somewhere down the line, a subset of them developed a mutation. And if this subset of them is developed in the gametes, or the sperm or the egg cell, and it gets passed on to the offspring, then they could have the have a mutation. And so this is something that in genetics is always kind of a possibility. And so we can never really rule it out because it's difficult to tell if a parent is mosaic, because their testing wouldn't show it. If you test them, they won't show up as a carrier. So now
Taylor, we have a question, if that's okay.
Sure, yeah.
So is it true that most mutations occur in the carrier mother?
So given the, yes, so given the, let me go back to, the way this inheritance pattern works is that the typical way is that we do see a carrier mother passing it on and a son being affected. And the reason for that is that because it's X-linked recessive, for a woman to be affected, fully affected with hemophilia, we'll talk about some of the features of carriers, but to have the full hemophilia, she would have to have two copies mutated, which is just less likely. In general, recessive conditions are rarer because you have to get it from both parents. This is unique in that it's X-linked, and so males only need the one copy because that's the only copy they have of the X chromosome.
Great, thank you.
Okay. So von Willebrand's disease is caused by a mutation in the VWF gene, which is responsible for von Willebrand factor, and it's located on chromosome 12. And this, unlike hemophilia, like we just talked about, which is X-linked recessive inheritance, this follows a couple different inheritance patterns. And so type 1 is mostly dominant inheritance, and that's the most common type. And what I mean by dominant is that you only need one mutated copy in order to be affected. And so we don't talk about carriers in this case, because in this case, if you had one mutation, you would be affected, and then if you pass that on, your children would also be affected. And so again, it's a 50% chance that you pass it on, and if you pass it on, they'll be affected. And so type 2, we see some dominant and some recessive, so it's a little bit of mix of this. And recessive, as I sort of explained when I was talking about X-linked recessive inheritance, autosomal recessive inheritance, again, you need two copies, but it's not involving the X chromosomes, what is a little bit different. And so this is chromosome 12, so we have two copies. Everybody has two copies of chromosome 12, and you would need to inherit a mutation from both parents in order to be affected. And in this case, again, we talk about carriers, and carriers are people who only have one affected, one mutation. So they've got it from one parent, but not from the other. And so any other questions? And if not, I will move on to some case examples.
The question that came in, Taylor, is why is it different from brother to brother who are from the same mother, but they have a different mutation?
A different mutation? So it could be different from brother to brother. One could be affected, one could not be affected because there's a 50% chance that they inherit the mutation from their mother. Is that what the question means? We would expect that the brothers would have the same mutation if they got it, if they both came from the mother. So maybe one brother had a spontaneous mutation, the other one inherited from her mother. I'm not sure how, if I'm understanding the question correctly.
Yeah, we could ask more in the chat, and then maybe we can come back a little bit later.
Okay, yeah, we can revisit that question. Okay, so moving on to some case examples. So I tried to pick some examples that I thought would demonstrate some typical scenarios or some situations where either someone has a bleeding disorder and is going to a genetic counseling session for themselves or for a prenatal or a preconception case. So the first example I'd like to share is a 30-year-old pregnant woman named Angela comes in for a prenatal genetic counseling appointment, and she's 15 weeks pregnant. And she was referred to genetic counseling because she told her midwife that her brother has hemophilia A. And so this is her first pregnancy, and her husband is, 31 years old, and he's reportedly healthy. And so what would be the genetic counseling plan for this situation? So first we'd want to ask why she's coming in. Some patients come in, they don't know what genetic counseling is, they're unsure of why they're being referred, and so we'd want to make sure we answer those questions. We'd first want to ask about her pregnancy history. Has she had any other pregnancies? Has she had any miscarriages? Things like that. We'd ask about her medical history. So does she have any health conditions or anything worth mentioning? And then we take a family history. And taking the family history is important to get a sense of what's going on and get the big picture. And then if testing options are appropriate, we would discuss the benefits and limitations of testing options and decide what to do moving forward. So let's say that this is Angela's family. And so just to orient you, squares are males, circles are females. This is the baby, the pregnancy. And then the shaded represents hemophilia. And then over here, this different shading represents some breast cancer. So in looking at this family, does anybody want to mention some things that you think the genetic counselor would want to talk about with Angela?
Let's see if we have anything in the chat. Chance of Angela being a carrier.
Yes, definitely. Exactly. So that would be the main thing that I want to talk about. And the other thing would be, so going along with that, the chance that Angela's a carrier, and then the chance that she could pass it on to the pregnancy would be the other kind of side of that. And then also along with that, the chance that her sister could be a carrier too. And so she may want to talk about that with her sister. The other thing that I'd want to talk about is this history on her partner's side of breast cancer. So although she's coming in for hemophilia, this is something that I want to talk about, seeing these really young breast cancers. I'd want to talk with her about that as well. So to review what I talk about with Angela about hemophilia A, the risk for the pregnancy. So Angela's mother is a carrier, and so there's a 50% chance that Angela and her sister are also carriers. And if Angela is a carrier, there'd be a 50% chance that she passes the mutation on to the baby. And if it's a boy, he would be affected with hemophilia, and if it was a girl, she'd be a carrier if she inherited it. And then I want to review that inheritance pattern of hemophilia A that I talked about earlier. And then I want to talk about the potential delivery complications. So as I mentioned earlier, there are some concerns for carriers. There's a misconception that many people think hemophilia only affects males, but there are some concerns for carriers. And so I'd want to make sure that she knows about that so she can prepare for her delivery. So carriers can be at risk for a postpartum hemorrhage because the levels of factor VIII fall shortly after delivery. And then the breast cancer in her partner, as I mentioned, I want to see if they've had genetic testing for that. Her partner would qualify for genetic testing if he were interested. And then maybe I'd refer them to a cancer genetic counselor to talk about that with them. And then some testing options. For Angela, I would definitely recommend carrier testing, and that would be genetic testing or molecular testing of the F8 gene. So factor VIII clotting activity can indicate a carrier, but it's not a reliable predictor of carrier status because, as Rich sort of mentioned, the clotting activity can vary with things like exercise and pregnancy, and so it's not a reliable predictor of carrier status, but it would be helpful information to know for her in her pregnancy. As I mentioned with those delivery complications, if checking her clotting activity towards the end of her pregnancy would be helpful to know if they need to have factor on hand or anything like that during the delivery. And this information of her carrier status would be helpful for this pregnancy and also for future pregnancies. So some of the testing we do during prenatal period is specific to the specific pregnancy. So things like the Down syndrome screening and things like that is really specific just to that pregnancy. But carrier testing is something that is knowledge for all future pregnancies as well, and for yourself as the pregnant woman. And so some testing options for the pregnancy. If Angela is a carrier, she may want to consider some diagnostic testing, which would be an amniocentesis, or if she were earlier along, she could have done a CVS, but at this point it would be an amniocentesis. And then we could talk about some other screening test options, which would be like a quad screen, which is a screening test to look for the risk of differences in the number of chromosomes. So it screens for conditions like Down syndrome. So that would be just another optional test. And then, of course, we want to address any of her questions and concerns and help her make these decisions and help her have a plan for next step. Any questions about this case? I can't see the chat. Okay, I'll keep going and we can answer questions. Okay, so the next prenatal consult case is about VWD. So this is a 36-year-old pregnant woman whose name is Meredith. She comes in for a prenatal genetic counseling appointment at 12 weeks. And she was referred to genetic counseling for a very common indication, advanced maternal age, which basically just means that you're pregnant over age 35. And so this is her second pregnancy and her partner's 35 and healthy. And so the genetic counseling plan here would be very similar to the first one. You know, ask why she's coming in and get an understanding, ask about her pregnancy history, and ask about her medical history. And this is where she would likely share that she has VWD. And so that's important to know. And then, of course, taking the family history as we did in the previous case. And if this were the family history that Meredith shared, you could see that she's here and she has VWD. And she shares that her father also had it. And so with this, what are some things that you think we'd want to talk about with her, with Meredith? If anybody wants to share, if not, I can.
The type of VWD came up?
Exactly, yeah, definitely. So that was one of the first things that I was thinking. What type of VWD does she have? Knowing that is important to do a risk assessment for the pregnancy, because as we talked about, different types of VWD have different inheritance patterns. And so if she had type 1, that would be autosomal dominant. And so there would be a 50% chance that she passes it on to the pregnancy. Versus if she had one of the other types that has an autosomal recessive inheritance pattern, her partner would have to be a carrier in order to have the child be affected. So like, because she's affected and the father's affected, this looks more like the autosomal dominant type, but we want to confirm that with her.
Yeah, a couple of other things in the chat, Taylor.
Sure.
Explain that she could pass down the condition, the possibility that her VWD is passed, blood type affects VWD levels and does pregnancy.
Yes, yeah, those are all great. Thank you for those responses. And so going along with affecting pregnancy, I'd want to make sure that her OB knows that she has VWD. Similarly to the last case, we'd want to take a look at her VWF and factor VIII levels closer to the third trimester of pregnancy, again, to get a sense of maybe if she needs to have some factor on hand for delivery to prevent any bleeding there. And so for testing options, I wouldn't recommend any testing for the pregnancy at this time for VWD. It's something that as the child's older, if they have features, they could have testing for, but probably wouldn't test prenatally. And then I mentioned that her original indication was for advanced maternal age, and something that we offer women who come in for that indication is what we call NIPS, or non-invasive prenatal screening, which is a blood test that is very similar to the quad screening, and it screens for differences in chromosomes of the baby. So it would be a screen for Down syndrome and conditions of that nature. Okay, on to the third case. So this is a preconception consult example. So here we have a 28-year-old man named Nick, and he has hemophilia B. His wife, Gina, is 31, and she's healthy. And the couple would like to start a family, and they're referred to genetic counseling. And so they come to the consult together. And so the plan here, similar to what we've talked about before, you know, asking them what they hope to learn, what brings them in, asking about their pregnancy and medical history and taking that family history. And so in this case, you can see this would be any future pregnancy. And we have Nick here, he's has hemophilia B. His mom was a carrier. So what do you think we'd want to talk about with Nick and Gina? What would be, does anybody know what the risk would be to the pregnancy given that he is affected?
So it looks like if female child, she would be the carrier.
Yeah, exactly. So we know that men who have hemophilia, all of their daughters will be carriers.
Yeah.
So,
yeah.
okay, so hemophilia B, so the risk for future pregnancies, as we just said, all future daughters will be carriers. So in theory, future grandchildren could be affected because if they have children that are carriers, then the next generation could include some boys and they could have hemophilia B. And then all future sons from Nick will be unaffected. And I put a little caveat there because, you know, they could have a low risk to have a de novo mutation as we talked about, but it wouldn't be that they inherited it from Nick. And then, you know, we'd want to review the inheritance pattern with them. And we would take this as a time to talk about some of the screening options during pregnancy. And so in a preconception appointment is a nice time to review kind of the process of screening. So reviewing when you have ultrasounds, aneuploidy screening options, and carrier screening options as well. So lastly, I'd just like to take a little spin on that last case. And what if Gina were the carrier and Nick were unaffected? What do you think? What do you think we'd want to talk about there? So let me so we have pretty much the same plan, except the things we talk about would be different. So if this were the scenario, anybody have any thoughts on the risk for the baby or future pregnancy?
There's a 50% chance the boy would have hemophilia.
Yes. And so 50% chance that she passes on the mutation to future children. If it were a boy, they would be affected. And if it were a girl, she'd be a carrier. And then we want to discuss other family members. And again, given that Gina is the carrier in this scenario, we'd want to let her know about those potential delivery complications given that she's a carrier. And then, so in this case, because it's preconception, we talk about some options for pregnancy. And so there's 3 options that I would like to talk about. The first would be to achieve pregnancy naturally or by IVF and wait and see if the baby has hemophilia when they're born. Another option could be to achieve pregnancy and then do testing of the pregnancy via an amniocentesis or a CVS to see if the baby has hemophilia and to use that to guide the pregnancy. And then the third option is something called pre-implantation genetic testing, which uses IVF and they test the embryos to see if they're affected, and then they select the unaffected embryos and use those for IVF. And so this is a newer kind of technology, and the specific mutation must be known. So that's a key feature of this. It can be expensive and it's not always covered by insurance. And it takes time to develop look for the specific mutation in the embryo. So that's an option, but it can be limited by the cost and time. Okay, and so I just wanted to wrap up and then I'll take some questions. So in summary, genetic counselors often meet with people with bleeding disorders and or a family history of a bleeding disorder. and they can help with providing risk assessments for individuals and their family, and for carriers and for future pregnancies. We can provide information about testing options and then provide support to families as well. And I wanted to share, I know someone had asked, how can I get one? I wanted to share this link, NSGC is the National Society of Genetic Counselors, and they have this resource here at this website where you can put in where you live, and it'll let you know where some genetic counselors are nearby. And I will also say that there are genetic counselors, many genetic counselors in the Boston area, so they're definitely around. And now I'd like to open it for questions, and I will try to get back to the chat window. Or feel free to unmute yourself as well.
Yeah, so as we go through here, first off, fantastic job. Those case studies learn quite a bit. Incredible to kind of see this here. I'm gonna go through the early questions of the chat, but some of the more recent ones that came up is, does insurance cover genetic counselings, and do hemophilia treatment centers, which are federally funded, offer genetic counselings as a service?
Yeah, those are great questions. So I will say it depends on the insurance plan. From what I've seen, it seems that most insurance will cover if you have a first or second degree relative that's affected. However, they often require a prior authorization, which is kind of a first step before that gets like a pre-approval. And so that's something that I've seen for it. It depends on the insurance company, depends on where you are in your plan, I'll say. But if you have a first or second degree relative affected with hemophilia or a bleeding disorder, it would be something to talk with your genetic counselor about. You're concerned that it's covered, but they could help you initiate that prior authorization process.
Great. Some other questions that we had that came in is, because there is phenotypic variability in hemophilia A patients, how do you determine specific treatment options?
That is a great question. I am not familiar with the specific treatment options for the different types of hemophilia. I'm not sure if anybody else in the group has any insight on that.
I'm not completely sure about this, but Rich, correct me if I am wrong. But I believe when we're talking about like factor supplementation, the factors would differ between hemophilia A and hemophilia B, but practically like day to day, that wouldn't change much. But if we're thinking about like potential therapies that could happen in the future, the delivery modes and the opportunities available might differ based on different mutations. But this is something that there is still a lot of uncertainty about. So I think we could predict there are differences, but it's hard to say what those differences might be at this time.
Yeah, I think you're spot on there, because the earlier question about mutation was clarified about inhibitors. So it was two brothers, one formed an inhibitor, one didn't, from the same mother. So the mutation should be the same, but why did one person why one brother? And I think the question, if I'm reading it correctly, was, is that a mutation issue, or is that more of, other elements there?
Yeah.
Do you have a thought on that, Taylor?
Yeah, that's a great question. It's something I read up on a lot, because I know that is a major concern for people in the bleeding disorders developing that inhibitor. And I don't think that they know I don't think they've made a link between certain genotypes or specific mutations being more likely to form an inhibitor or not. Tori, have you read anything about that?
I have not. I'm just hypothesizing at this point, but I could guess that even though the brothers share the same mutation, that perhaps they differ in other genetic aspects of how their body forms antibodies and how their immune system works. And that even though they're brothers, they're still 50% different. So perhaps like their immune response is different in some way for a genetic or another reason. And so that's what comes to mind, but I don't have any data to back that up.
Yeah.
Good answers, both of you there. Another question that came in the chat is, being in the bleeding disorder community, is it wise to meet with a genetic counselor before each pregnancy?
So I think it would be a personal choice. If you want to better understand, you know, the inheritance and the risk to your pregnancy, certainly it would be helpful to do. If you're looking for testing, then like testing each pregnancy, then that would be something you would have to do each pregnancy. So it depends on what you're looking for, what information you're seeking.
Okay, great, thank you. Another question is, what age is recommended to have a potential carrier tested, as a child or a teen? Great question.
That's a great question, yeah. So as a carrier, so if they're not showing any symptoms or any features, we probably wouldn't recommend it until they're old enough to decide that for themselves. You know, but it's different if they're showing features or symptoms, then we would recommend testing.
Great, thank you. Another question, how do you educate families that genetic counseling is available to them? Doctors don't always mention it.
Yeah, that's a great question. So how to educate families? So we, you know, as genetic counselors, we always try to advocate for the field and for genetic counseling, because we do hear this often that people don't know about genetic counseling. They don't know what it is, which is why, you know, webinars like this is what we're trying to do, is let people know about it. I don't know what the answer would be to tell doctors. You know, some doctors know a lot about genetic counseling and they're very willing to refer and it's on their radar, and others just prefer to order the testing themselves. And so, yeah, it's a challenge in our field, I would say.
Great. Thank you, Taylor. Outside of bleeding disorders, which many patients know that they have, can genetic counselors help to determine other genetic risks or conditions?
Yeah, yes, we see many different patients for many different reasons. As I started to mention earlier, you know, there's different specialties of genetic counseling. So some people go to genetic counseling for like a cardiac conditions that are running in the family, and they want to know the risk for themselves. You know, cancer predisposition to certain cancers, that's another one that many genetic counselors meet with patients for if they have a family history of lots of cancer and they want to know their risk. There's genes that we know are related to certain cancers, and so that's another thing. Many patients go to genetic counselors with their child if they're having developmental delay or some intellectual disability, things like that. And those are all different examples of scenarios. And there's many more.
Great. Thank you. Questions keep coming in for you, Taylor.
Yeah, I love it. Thank you all.
Yeah. Does genetic counselors recommend tests and then another doctor performs them? For example, pre-implementation genetic testing.
Okay, so typically, for like carrier testing, it would basically be like you would meet with a genetic counselor, talk about testing. If you want to do it, the genetic counselor could order it for you, and then they would probably call you with the results. Or they would have you see them in person, depending on what their clinic does. Things like pre-implantation genetic testing are, that would probably involve an IVF clinic, because they would be involved with that as well. And so that would probably be a collaboration of meeting with a prenatal genetic counselor, and then coordinating that with the IVF clinic that you're using as well.
Great. This question, I can help answer it. So, was My Life, Our Future considered genetic research? Do you got, Taylor, do you know about the My Life, Our Future?
No, I'm not familiar with that.
And feel free for others to weigh in. So this was a collaboration with the National Hemophilia Foundation and Biogen in particular, and a couple of other companies. And maybe it was only Biogen, but it was free genetic testing at the hemophilia treatment centers to understand mutation. And then they opened it up to women to find the genetic mutation. I haven't seen a lot of the results, but I know as patients, you got something mailed to you about your mutation. So that was super interesting. But I believe there was over 5,000 people that participated in it. And I was almost going to say 10, because I believe it is as high as 10 that participated, but it didn't cost patients anything, which is great.
Yeah, that's great. And there are studies out there like that, you know, with genetics, the more information we have, the more we can learn. And so it sounds like they're trying to collect information on different mutations and things like that.
Great. I'm going to put the link in the chat for the website if anyone's interested. Is it considered a unnecessary cost to have genetic counseling, and why is it not discounted as much from some doctors?
So actually, many insurance companies prefer that you have genetic counseling and will cover it if you have genetic counseling. So in that sense, it's seen as an advantage, because they know that genetic counselors will order the right tests. And so in the end, for costs and things like that, it works out. So, so that's actually something to consider, is that sometimes you have to have genetic counseling in order for it to cover, for your insurance to cover it. I don't think that's all insurance companies, but it is something that some do. And then why it's not discussed as much with some doctors, again, yeah, it's a challenge. I think it's becoming more discussed with doctors. It's also, genetic counseling is a growing field, relatively new field. And so there's more of us now that we're reaching more areas of the country. And but if people live in an area where there's not any nearby, and it would be easy to not, to know about it as a doctor and make that referral.
Great, thank you. Is there a VWD mutation database?
That's a good question. So I don't know.
Yeah, I don't know.
I'm not sure. I would think that there would be. In doing my research, I saw on what we often use is gene reviews, which is a good resource for learning about genetic conditions. And I saw they had a bunch of the mutations listed there, but that's certainly not a database. That's a good question.
Yeah, and I'm going to put another link in the chat. Nearly 10,000 hemophilia patients with A and B did get genotyping through My Life, Our Future. It did not include VWD, but Carol, I hope that the next phase of this does include other rare bleeding disorders and VWD, but it looks like it was Hem A, Hem B, and then carriers, but great question there.
Yeah.
Are results private? Can results be used to discriminate with insurance companies?
Yeah, this is a great question. So there is a law that's called GINA, the Genetic Information Non-Discrimination Act, and it helps to protect people from genetic discrimination. However, it doesn't cover life insurance, long-term care, and disability. So that's something to consider. That's something that we talk about with people, especially it comes into play with the hereditary cancer syndromes, because many of these people don't have cancer yet. And so they don't have an actual diagnosis that their insurance would see that would affect, their health coverage. But they're learning that they have a mutation and that puts them at a higher risk for cancer. So that's where that comes into play. But for people who already have a diagnosis of a condition, already have pre-existing health conditions, it's less of an issue, but still something to be aware of. But there is a law that helps protect against genetic information.
A couple more questions here.
Sure.
Firing away, you're like up to bat and you're just
I know.
hitting them. Those
It's kind of fun.
Starting to do VWD. Oh yeah, yep. Thank you, Bree. Yep. So they were starting to do VWD with My Life, Our Future before they changed to. So companies in the bleeding disorder community often get bought out or they merge. So I don't know an update on it, but I'm happy to look to see if Sanofi Genzyme is going to continue the VWD My Life, Our Future. Another question, can one then, I think this was to your earlier comment, Taylor, can one then be tested anonymously?
That is also a good question. Can one then be tested? And honestly, I think it depends on the clinic. And yeah, I'm not sure about that one. It's something you could talk about if you're concerned. Talk about it with your genetic counselor. See if it's something they're willing to do. I've seen that be the case in conditions like Huntington's disease. I've heard of them doing testing anonymously through that, but it would be probably depend on your genetic counselor and what they're comfortable with, but something to talk about.
I think this is my favorite question of the night. What was your favorite part about being an intern with Neha? I love that question.
Thanks, Tori. I loved meeting the staff, Rich and Sarah and Gabby and everybody has been so wonderful that it's just been really fun working with them. And I love learning about all the different programs that they do, and it's just been fun.
Yeah, this is the most unique internship because there's no in-person events. I know many of our past collaborations with interns have been able to come to the walk or Fall Fest in person and do this presentation or other events. But Taylor, you've been great to adapt as we're all still adapting to this virtual format here. So great answer there. A couple more questions. Is genotyping, this is actually something that I was curious of too, is genotyping the same as genetic testing? Is it a semantics or is it actually two separate things?
So it's different. It's looking at different things. So genetic testing, as I said before, there's many different types. There's genetic testing that looks for small changes in the sequence of the gene. There's some that look for big gains and losses, big deletions and things like that in the gene. So it's different. It's not the same as genetic testing. So you want to clarify that. Great.
All right, last question here, unless there's others. Nope, we have two. Well, I'm going to go to Nancy's first. We hope to meet you at some of our in-person events next year. So as Tori knows, once you're with Neha, sorry, you're always, you're not going to escape here. So
Here somehow.
Yeah,
I hope we go to some in person too. Meet you all in person.
which would be great. Is it hard to work with families who might be very nervous about their results?
I love that question. So that's where the counseling side of genetic counseling comes in. We know that this information can be difficult. It can have big impacts on your family, on your own health, and we are there to, work you through those feelings. So I think it's very normal to be nervous about your results. And I wouldn't say it's hard to work with people who are nervous. I think it's very common and something that is not something to deter you. I think if you want to have the testing but you're nervous, I think that just talking with the genetic counselor more about how you're feeling about that is totally reasonable.
Great. All right, a couple more here as we're approaching the 8 o'clock hour. How many genetic tests can you do at once if you have multiple family conditions that you want to check before pregnancy or other times in life?
Yeah. So it depends on what you're looking for. So with pregnancy, there is, if you're looking to look at a lot of things, there's something called expanded carrier screening, which is a test that looks at many different autosomal recessive conditions and some X-linked conditions that, and it'll let you know if you're a carrier first. So that's one way to look at many different conditions at once. When you do like cancer, looking at the cancer genes, they often do it in what's called a panel, where they're looking at many different cancer genes related to, say, breast cancer, if that's what you're there for, or you could look at all the cancer genes. If you're looking for things like hemophilia, they typically wouldn't do it in a panel because it's usually we usually have information from the family. So they would be looking specifically at, the F8 or F9 gene and looking to see if you have a mutation there. So if you are concerned about multiple family conditions, certainly you could talk about that with a genetic counselor and they could work out what testing would make the most sense. There's not really a test that just says, here, we're going to look at everything, and, it would be more of a catered approach of picking which tests would make sense.
Great, thank you. All right, last question of the evening here. How did an hour go by so fast? Can you connect a patient with a research project, say sickle cell disease and CRISPR gene editing cure, in quotations?
So, so you mean personally as a patient, letting you know about a research project that you want to be involved in, or doing research on like certain, okay, so the first one, okay, yeah, so that's something genetic counselors often do is if you're interested in being involved in a study, they can help you find any research studies that may be of interest to you and help you with that process, certainly.
Great. Awesome. Well, Taylor, again, I'm going to give you the final words here, but thank you so much. And thank you to the Boston University Genetic Counseling Program. We are so thankful to have this experience for the third year in a row. And it's a great collaboration. I know the bleeding disorder community is very appreciative of this, and you guys bring a fresh sense, and we appreciate the help. So thank you. So I'll turn it back over to you, Taylor, to tell us about our upcoming events.
Yeah. Well, thank you, Rich. And thank you, Kathleen and Tori, for joining. It's fun to see you.
Thank you, guys.
For joining the conversation as well. And so I just wanted to let everybody know that NEHA's Fall Fest is coming up and registration is open. And so check that out. And then we have what's the webinar next week, Rich?
Yeah, that's a great question. And oh, I do know it. Sorry, I was drawing a blank. It's Meet the NEHA board. So you'll have an opportunity to meet the NEHA board, ask questions. It's the unofficial kickoff to Fall Fest, and then we'll transition into a pumpkin carving event Friday night. Everyone's going to get a kit where you get pumpkin carving tools and a gift card. And then followed by, and in the kit, you'll have these very cool handmade unique bars with cookies and several other things. And then the education Saturday and Sunday morning there. So please join us. It doesn't cost anything to join us. It would be a really great time. There's a scavenger hunt for kids. There's an exhibit booth. There's lots of fun interaction there. And Taylor will be helping us out with that. So thank you.
Yeah. I just want to say one thing, Barbara, that's wonderful that you're a prospective genetic counseling student. Good luck. It's a great field.
Barbara, if you would be interested, maybe, Taylor, can I connect you guys?
Sure, absolutely.
Okay, great. Awesome. Fantastic. Well, thank you everyone for joining us this evening. This will be recorded and put on NEHA's YouTube channel. And again, thank you to the Boston University Genetic Counseling Program, Kathleen in particular, for believing in NEHA and continuing this partnership. So have a great night, everyone. Great job, Taylor.
Thank you, everybody. Have a good night.
Thanks.